That excellent talk. Next, I invite Dr. Anitha Prabhakaran for her update on progressive myopia.
A very good morning to each one of you present here. So we are going to talk about something very important these days. We have been finding this very often, much often than what we have seen when I started my practice somewhere in 97. This is really something which is on the surge. So first of all, let us just define what is progression. Progression means when the myopia increases more than 0.5 diopter per year or an increase in axial length of more than 0.1 millimeter per year. So that is the definition of progressive myopia. And one more thing which is actually progressing is the prevalence of myopia as well. As has already been described, the prevalence of myopia in Indian children has also been on the increase. So that is also another progression we are noting. So risk factors for myopia holds true for risk factors of progressive myopia as well. Most of them, like age of onset, earlier the onset, more the risk of progression. Females, they say the reason is being females are more prone to be indoors. Parental myopia has already been described. Asian ethnicity, it's been found that children of Asian origin, even if they reside elsewhere, they are still found to have progression in myopia, and that is postulated to be attributable to the parents being highly academically and oriented, and they insist that the children, more than the other nationalities, Asian children are more into academics, and that is supposed to be one of the reasons. Again, early schooling and curriculum, same reason, and of course increased near workload, which Samyukta mentioned about the accommodation influence, and the syndromic associations like Marfan's have already been mentioned. Genes have a important role to play. Baseline refractive error, we said we categorize about plus 0.75 to minus 0.5 diopter baseline refractive errors to be pre-myopes. We have to take more care so that they don't progress to progressive myopia. And visual environment has already been mentioned, but I'll talk about it a little bit later. And relative peripheral hyperopia, lack of accommodation, and esophoria for near is also noticed. All of you must have heard of the bullet trigger theory, that is a gun loaded with bullets of children with high myopic parents is like a pistol loaded with bullets, and whenever there is any risk factors, like any of the risk factors, it's actually a trigger being pulled, and more number of triggers being pulled, more number of damage and more complications follow. Ocular expansion has already been mentioned, how globally, equatorially, only the posterior pole, axial or an asymmetric enlargement of the globe happens, and the various postulations have been, most importantly, one has been because of the changes in the sclera, because of the proliferation of the chondrocytes, and the ocular muscle pull because of the accommodation convergence abnormal correlation. And another postulation is the adolescent stage. There are lots of internal changes happening which leads to the rapid growth, and calcium deficiency has also been postulated in a study, and it could be, in a way, when we are now talking about that vitamin D is a reason for a progression of vitamin D deficiency is a reason of progression of myopia, and it could be related to calcium deficiency as well. It's yet to be, lots of study need to be done. So as we all know, why are we worried about progressive myopia? Because higher the myopia, once it goes into the pathological myopia, there are more risks. I just wrote very few. There are lots of risks, just like Dr. Malligam explained, like there are amblyopia, glaucoma, cataract, myopic macular degeneration, lacquer cracks, SCNVM, staphyloma, retinal detachment, so on and so forth. So why are we concerned about how can we really control the progression? So one factor we need to remember is that the risk of developing myopic maculopathy decreases by 40%. It's very significant if we control the progression rate, but by at least 1 diopter during childhood. So this was actually, this came up in the impact management guidelines. I'll come to it by the end of it. So what are the various interventions we can do? there are pharmacological interventions, there are optical interventions, very, very important. Added to all these would be lifestyle modifications, and a recent light therapy has also been mentioned. So about pharmacological measures, we are all dealing with muscarinic receptors or xanthine derivatives or IOP lowering agents, of which muscarinic receptors holds good even at this time, and of which the most commonly used one is atropine of various concentrations, 0.01%, 0.25 and 0.5%, but the one which we most commonly use and is commercially available is atropine at 0.01%. It's actually it's a muscarinic antagonist acting on all receptors, but the M1 and M4 receptors are involved in the myopia control, and we need to understand that atropine does not affect the progression of myopia through an accommodative mechanism. All of us might think that this is because of the pupil dilatation. No, this is actually it's a non-accommodative mechanism. How it does is, it has a effect on the dopamine neurotransmitter release, and this dopamine is actually what is affecting the control of the it has control on the retina and the sclera, and therefore it affects the progression in length of the globe. So the low dose atropine, usually in clinical practice we start now the consensus is start by around 5 to 15, between children in 5 to 15 years, and the progression needs to be documented. Only when the progression is documented, you need to start, you need to do cycloplegic refraction, axial length measurement, pupil size, accommodation and visual acuity. And after 1 year, if there is poor response is children who progress more than 0.75, even after the atropine. If less than 0.25, it's considered as good response, and between moderate response. So usually we give for 2 years, and then after 2 years we start tapering. That is what is recommended. And optical treatment is especially when those with relative peripheral hyperopia, which is demonstrated by peripheral refraction, we should go for peripheral defocus glasses or multifocal lenses or orthokeratology. Or those with MEM refraction, we get an accommodative lag or near-esophoria, you go for bifocals or extended depth focal. So lifestyle modification, very, very much to be emphasized. At least 90 minutes or 2 hours per day of outdoor activity in good sunlight, and take breaks. Allow only 30 minutes of screen time and maintain posture. And low level red light therapy is another new thing coming up. We are not using it. So it has to be tailored. It's nothing like one size fits all. We need to look at various options and decide, especially in case of optical measures, we need to think about the parents' financial capabilities as well. So there were studies, Atom 1, Atom 2, LAMP, and the impact study, impact guidelines have been put up in the recent IGO, and they all deal with how we can manage the progression of myopia. So as we can see here, every 1 diopter increase in myopia, this is how the child gets blurred. So it does affect their academic and socioeconomic. It has a big socioeconomic burden, and therefore it is the need of the time to control progression of myopia. Thank you very much.